Thank you for joining us this evening for Lupus Canada's Disease Awareness Webinar. Tonight, we're honored to have Dr. Roger Levy join us. Dr. Levy is currently a global medical expert in the specialty and medical care franchise with GSK. Dr. Levy's bio is quite impressive. So there's so much to list, so I invite you to go to our website to learn more about Dr. Levy. This evening, Dr. Levy will discuss empowering women living with lupus by educating them on lupus, pregnancy, fertility, what to know, what to think of, questions to ask, things to consider. Before I pass the baton over to our moderator for this evening, there are just a few housekeeping items that I'd like to address. All attendees are placed in listen-only mode, therefore your audio and video are disabled. Should you have a question, please put it in the chat box and we will be sure to address those at the end of the webinar. We hope you find this webinar informative. I will now pass it over to Ariana Ranjabar, who is our moderator for this evening's webinar. Ariana?
Thank you, Leanne. Yes, so I'll just reiterate that I'm the moderator for tonight. So if you have any questions throughout, please feel free to put it in the chat box. And if it's urgent, I'll try to address it right away. If not, then we'll just wait till the Q&A and have Dr. Levy answer any questions. Thank you so much for joining us tonight.
Thank you, Ariane and Leanne, for the invitation, the introduction, and thank you all for coming here tonight. It's a real pleasure for me to talk about, I can tell you, my favorite topic. I'm a rheumatologist. I trained at a hospital for special surgery in New York in the late 1980s and early 90s when talking about family planning to people living with lupus was almost a dogma, a forbidden topic. But then with time and with the science and everything that we learned over the years, as a professor, I taught my students and residents on how to make this a reality and talk to patients about family planning, about the right timing for pregnancy, and also demystifying many of the dogmas that we had at that time. So this is what I wanted to talk to you about. As Leanne said, I'm a employee of GSK. I live here in Philadelphia, outside Philadelphia, and I'm a global medical expert. So we hope that within the next half an hour or so, we'll be able to talk to you and explain to you how to counsel people living with lupus on family planning. We're going to focus on the proper timing, and this is the key learning of the whole presentation, the proper timing, and when and how to adjust the treatments to experience uneventful pregnancy with the disease under control and hopefully a healthy offspring to go home. We want to talk to you about what are the factors that influence the results of pregnancy in a person with lupus. What are the predictors of the different outcomes in lupus pregnancy? A little bit about anti-Ro SSA and the role that it plays in neonatal lupus, and also a little bit about antiphospholipid antibodies and obstetric antiphospholipid syndrome. So in general, fertility is well preserved in people living with lupus and other rheumatic diseases. We know that there are some certain drugs that can interfere with fertility, some temporarily, others permanently. And also the disease state, if the patient is under a flare or has more damage, this may interfere not with fertility itself, but with their sex life and then the ability to conceive. My campaign over the years was teaching my students and everybody that I could to talk to people living with lupus about, ask this question: would you like to become pregnant within the next year? Why is that important? Because this changes the way we plan the treatment. The doctors usually have a treatment plan that should be aligned with the patient's plans. But if the patient doesn't share what their plans are, it's impossible to know what's best and what can we offer for a pregnancy. So my message is, we hope that pregnancy is not a surprise for people living with lupus. You should talk to your physician, rheumatologist, other specialist when this comes to your mind, because we want to be on the patient's side and help, like I said, make things go on the best way possible. This is knowledge that we had for so long, and it's again being confirmed. And there was just at the last American College of Rheumatology meeting more papers about this, that NSAIDs are related to temporary infertility, the higher the dose. So it's a dose dependent and time dependent. So sometimes, and this can happen with other disease also, like in rheumatoid arthritis, patients that are on continuous use of NSAIDs are less likely to ovulate. And like I said, this is related to ovulation, to dysfunction in ovulation, and to the rupture of the membranes too. So the higher the dose and the longer the use of NSAIDs, the less likely this woman is to conceive, but it's reverted after the treatment is withdrawn. And that's not valid for low dose aspirin. So we're talking about anti-inflammatories on the therapeutic dose. The immune system is affected by pregnancy. So we always say pregnancy is not a disease, but is a special state that the immune system needs to adapt, because there will be a new being growing inside the uterus that is at least half strange. So the mother's immune system needs to be adapted in order not to reject the fetus as if it was a foreign antigen. So there is more of what we call the Th2 response, similar to allergy. So anyone here that was pregnant remembers more insect bite, you have a high reaction, a stronger reaction. You have more stuffy nose and allergic manifestations. There's a whole adaptation with the increase of inflammatory, pro-inflammatory cytokines and a dysregulation of the cells that we call T regulatory. And these responses are physiologic in order to protect the fetus, but they will influence the way that pharmacodynamic of the medication that you're taking and the pharmacokinetics is going to be different in a pregnant woman. And you understand, for obvious reasons, that when we do a clinical trial, we are never enrolling pregnant and lactating women. And usually it's considered an adverse event. So they, when enter a clinical trial, patients sign the informed consent saying that they're not going to plan or get pregnant during the study. Sometimes it happens. And then these patients are excluded from the trial. The new drug that is being tested is stopped, and they are followed, but they're not counted in the trial. So most of the data that give us warnings about medication are based in animal studies. And it's not 100% of the animal studies that are translated into humans. We know that in the healthy population, you can have 3 to 5% chance of fetal anomalies, malformations, and if this woman was exposed to a new agent during pregnancy, most likely this agent will be blamed. So we need to have data from registries, from real life experience, since clinical trials with pregnant women are almost non-existent. And most of the warnings we have are not always because we know of an effect, but most of the time because we don't have any knowledge and no one wants to be the first one to learn. So it's a difficult area when we talk about new medication and pregnancy. We usually learn from real life. Until 2015, the FDA classified the treatments according to letters A, B, C, D, and X, but this classification is now outdated, and now they have like an active classification, active because it keeps on changing as new evidence is generated, and they call it the pregnancy and lactation labeling rule. And you can check this at the FDA website. But there are still those medications that we know are clearly not supposed to be used in women that are planning to conceive. So the preconceptional counseling is very important for all fertile patients. Usually, we ask for 6 months of quiet disease, of disease that's under control with stable treatment, and then we'll be able to adjust the treatment according to the guidelines. But there are these 5 situations where we would say we completely contraindicate pregnancy because this is going to put the mother's life at risk. Which are these? The pulmonary arterial hypertension when it's more than 15 millimeters of mercury, renal failure, meaning serum creatinine more than 2.8, patient with severe lung restrictive disease with the forced vital capacity less than 1 liter, patients with advanced heart failure, and those that at a previous pregnancy presented severe preeclampsia or the HELP syndrome despite therapy. So those are fortunately rare situations, but in those patients, we believe that the risk of pregnancy outweighs the benefit for the mother's life. Those 4 bullets here are situations where we would prefer to postpone conception, which are severe flare, especially if there is nephritis or a severe central nervous system manifestation like a stroke. And because the first 2 years of diagnosis are at higher risk of nephritis, and we don't know exactly what's going to happen with this person, we try to ask patients to postpone pregnancy in the first 1 or 2 years when they are diagnosed. I know it's much easier on a slide, on a piece of paper, but if that's possible, that's going to increase our chances of success. And there are guidelines, and this that I'm referring here is the 2016 EULAR guidelines. It's being updated, probably 2023 up to July, they're going to issue a new updated guideline, and your physicians can go there to look at the time frame before conception that each different medication needs to be withdrawn. Let's talk a little bit about effective contraception in patients with lupus. We believe that we should involve not only the patient herself, but also her partners and other people that can help, because this is a decision that needs to be taken by the family. We recommend not using estrogens in those patients that have the antiphospholipid syndrome, but also in those that have antiphospholipid antibodies. So checking for antiphospholipid antibodies before using estrogen is recommended, highly recommended, because they could be a trigger for thrombosis, and it could be a serious event. Believe also that the multidisciplinary approach is always a benefit for all of us. So it's important to align the recommendations with other specialists and plan for children and teenagers that sometimes need to use hormones for adjusting their periods or contraception. So knowing how long do you need this contraception for will help us identify the best option for this patient individually. We need to have an optimistic outlook. I was telling Ariana and at the beginning how much we learned over this past 30 years, and most of the cases have a positive outcome. But again, the planning is essential for both pregnancy and breastfeeding. And we are rarely contraindicating this to our patients depending on the time. So effective contraception is related to an optimal disease control. And when you have a patient conceiving at a period when the disease is well controlled, you're going to have better obstetrical, so the mother side, and the fetal, the baby side outcomes. And we should evaluate our patients using the validated tools. Depending on the medication that the patient is using, the contraception becomes even more important. And as I said, we don't want to be surprised. We want to have a planned pregnancy with a shared decision method to decide how long you want the contraception for and analyze the different options for that patient individually. You see here, I'm going to show you a study that was performed at the University in California, San Francisco, that showed that 86% of the patients were at high risk of unplanned pregnancy, regardless of the medication they were using. Even patients with medication that are known to be teratogenic were equally likely to be using effective or non-effective contraception. So this is very important, and we should learn from that. Almost 60% of the patients said they had no counseling in the past year about conception. 22% told the investigators they were using contraception inconsistently. 53% were only using barrier contraception, that we know is the least effective type. And the most effective, which are the IUDs, were only used by 13%. So estrogens do not increase the risk of flares. We avoid them in patients with active nephritis and those with antiphospholipid antibodies or the antiphospholipid syndrome, like I told you before. So what have we learned? That we need better counseling and planning. So share your plans with your physicians and let them know what you are planning in terms of conception and contraception. The IUD may be an ideal option, including those patients with antiphospholipid syndrome or the antibodies for a long-term contraception. And those were the comments I made when to avoid estrogen. The progesterone derivatives, oral, intramuscular, or in the intrauterine device, are not increasing the risk of thrombosis and can be used, including in those patients with a higher risk of thrombotic events. From my experience, the patients want to know what are the drugs that they can and cannot use during conceptional period, during pregnancy and lactation. They want to know about disease interaction. What would this pregnancy do to my lupus and vice versa, and the risk for the babies. During pregnancy, and again, I'm going to talk to you about timing and planning. We want to delay the more recent patients and those with active disease. We adjust the treatment according to the guidelines. The EULAR guidelines are also more recent, but there's also the British Society guidelines and the American College guidelines. We want to identify potential events and risk factors. So in addition to disease flare, mainly renal and central nervous system, we need to check for the presence of the anti-Ro, anti-La antibodies, because we know they increase the risk for neonatal lupus. It can be a transient manifestation with skin rash in the newborn, or it can be in 1% of those with anti-Ro, irreversible manifestation that is causing a heart block in the fetus. So some of them may need a pacemaker. It's very rare, but if we identify, we identify the woman with anti-Ro, we will try to diagnose the heart block before it's the complete heart block and try to revert it before it's complete, and then it's irreversible. Check for antiphospholipid antibodies in all patients. Sometimes it's easier to identify when they already have the antiphospholipid syndrome, but 40% of lupus patients can have one type of antiphospholipid antibody, and they can increase the risk of fetal complications. And I'm in favor of a multidisciplinary, even more multi-professional, high risk because it's close surveillance, not because we need to have a problem, but the multi-professional team approach improves results. A lot of the dogma that I spoke in the beginning were because many of the manifestations or clinical signs and symptoms of a normal pregnancy can be confounded with lupus manifestations. So any woman that is pregnant can say, oh, my knees are hurting. But if they have lupus, they're going to say, oh, she's developing arthritis related to lupus. There's hair loss in normal pregnancy. But again, on a lupus patient, it may be perceived as alopecia related to lupus. The cloasma may be mixed or confounded by the mala rash, which is characteristic of lupus. Carpal tunnel syndrome with tingling and numbness. 30% of normal women in the third trimester develop carpal tunnel syndrome. It's related to the edema of pregnancy, and it goes away when the baby is born. If it happens on a lupus patient, someone may think it's related to a lupus flare. Palmar erythema It's common in pregnancy. The later the pregnancy, the more pulmonary erythema. It's not due to lupus. The edema, it can be related to lupus with proteinuria, with nephritis. It can be due to preeclampsia, or it can be found in a normal pregnancy. Like shortness of breath, the same. But if our patient has really real arthritis and fever without an infection, then this is more likely to be lupus flare and not possibly related to pregnancy. You see, the pregnancy increases the blood volume, and you can have what we call dilutional anemia that you see in the hematocrit, but not in the hemoglobin concentration. So we don't even pay attention to the hematocrit in lupus pregnancy. Leukopenia, decreasing of white cell, it's more likely to be due to lupus and not to pregnancy. While decrease in platelets can happen both in a regular normal pregnancy. It can be a complication of pregnancy and more severe preeclampsia, or it can be other manifestation of SLE. The presence of anti-DNA antibodies are specific for lupus, like complement consumption. But complement, like the other acute phase reactants, increase in pregnancy. So you may have complement consumption, but it can be still within the normal laboratory value. So we measure complement serially, and we notice from this patient, if there is a decrease, then we can think of a complement consumption. The other tests like C-reactive protein, sedimentation rate, D-dimer are useless to be looked at for patient with arthritis or lupus during pregnancy, because they increase with normal pregnancy. So we lose the value of those acute phase reactance tests. So the SLE day is adapted to be used during pregnancy, and all of those that have a Y there had to be adjusted or modified for pregnancy. So you see, we have a tool that is used and validated to be helping us. It's not perfect, but it's the best we have to evaluate on an objective form if there is increase of disease activity, of flare during pregnancy. So this is the first part of the SLE day. You see some components like myositis, urinary casts are the same, but many others like headache, cranial nerve, Bell's palsy. So this could be all related to pregnancy complication or to lupus complication. So we need to differentiate those clearly to score and say it's due to lupus. I spoke to you about the cloasma mixing up with the rash, the alopecia, shortness of breath, the story about the complement. So it's possible that you still get confusion, but this tool here, the sleep day with the P for pregnancy, is very helpful for us to understand and to differentiate a lupus flare from other pregnancy-related complications or from physiological normal pregnancy by itself. What are those features that we can say are predictors of complications? So those recommendations I spoke before, patients that are getting pregnant with an active nephritis, they're more likely to have additional flares, relapses of nephritis, or not respond ideally to treatment. We have to change the treatment. We have to do a lot to save the mother's kidney function, and CNS disease can be a complication when it's already happening and the patient conceives with active CNS disease. I spoke to you about recent diagnosis, or sometimes when lupus is ecloding during pregnancy. So those patients are at higher risk of having a flare during pregnancy. Here, there's data showing that if the patient had a flare in the past 6 months, she has more than 7 times higher risk of flaring again during pregnancy than if she didn't have a flare in the past 6 months. The use of antimalarial drugs, we know for many, many years they are safe to be used during pregnancy and lactation for the mother and the baby. And when they are withdrawn, they increase the risk of a flare during pregnancy. So ideal 6 to 12 months of remission, especially renal and central nervous system before conception. Here's some data showing that women with a past history of nephritis, even if it was 2-3 years completed treatment, they can get pregnant, but they need even closer surveillance and attention, because we know they are at higher risk for flaring during pregnancy and also for having preeclampsia. So this study found that past nephritis, presence of lupus anticoagulant, uncontrolled hypertension, removal of antimalarial, and low serum albumin were predictors of more risk of active disease or a flare during pregnancy. This is meta-analysis of many, many papers conducted by our dear Professor Daphne Gladman from Toronto. She confirmed that those patients with a past nephritis, here in the lighter blue color, had more fetal complications, so low birth weight, and also the mother having more flares, significantly more than those that never had a history of nephritis. Another meta-analysis here with a huge number of pregnancies, confirming what we saw: past nephritis, presence of antiphospholipid antibodies are markers for increased risk for maternal hypertension and fetal prematurity, including intrauterine growth restriction and spontaneous abortion. So we need to have a plan, and we need to know when the patients are planning to conceive. And we need to align these expectations. We want this disease to be under control for 6 months or more. We have to adjust the medication. We need to identify additional risk factors like the anti-Ro and antiphospholipid antibodies. With that, we'll have a mother that will be during pregnancy and lactation with a well-controlled disease, avoiding harm to the fetus, balancing the risk and the benefit of therapy and not to treat. There are alternative ways to treat during pregnancy if necessary, avoiding the medication that can be harmful to the babies. and the shared decision-making, transparency, and multi-professional approach improves the outcomes. So, to conclude, family planning for people living with SLE needs to be carefully planned, and the decision based on the right timing and treatment adjustment. Conception must be at a period when the disease is quiet. Medication must be adjusted, not only the specific lupus medication, but all the medications that the patients are taking. And a high risk OB integrated clinic with rheumatology, other specialists, other professionals are helpful. And we need to align with other professionals and specialists that are caring for the lupus patients, what we are going to offer and the expectations. So with that, I think we can address your questions and comments. And again, thank you for your attention.
Thank you, Dr. Levy, for your presentation. We have a few questions, so I'll just get right into it. The first question is, do you know if IVIG therapy is safe in pregnancy?
Yeah, it is. IVIG is totally safe in pregnancy. I have experience. It's a treatment that we use in difficult situations, like in refractory thrombocytopenia. One of the other advantages of IVIG is that it's not immune suppressive, so it is used. We know that all the immunoglobulin G will only cross the placenta in the 3rd trimester. So definitely first and second, no risk at all. And later in pregnancy, risk and benefit, the fetus will be exposed to that IVIG, but it doesn't cause, it's not related to any harm in the baby.
Thank you. Okay, so the next question, I think I'm not going to say it properly, but it says, are Benlysta and rituximab usually stopped in pregnant women?
So I wasn't supposed to talk about any products, but if you're asking me, the recommendation, it's in the prescribing information of Benlysta, is that it stopped 4 months before conception. For that reason that I explained, lack of experience. And also at the prescribing information, it says that the decision needs to be individualized, doctor and patient in that situation, if the risks outweighs the benefits. We know that IgG, like Benlysta is an IgG, rituximab is an IgG, like IVIG that I spoke about before, will only cross the placenta and reach the fetal circulation in the 3rd trimester. So we didn't show increased teratogenicity with Benlysta in a recent publication. We still need to gather more information because we didn't do a study specific for that. We used the pharmacovigilance data and also the registry, and we still are waiting to gather more experience with the registry called Mother to Baby. So anyone that gets pregnant on Benlysta should ask their doctors to report it to the registry, because that's where we're learning from. With rituximab, and also I have some experience, it's reserved for more severe cases, because since it's going to cross it has a longer life than Benlysta. So it's crossing the placenta, and there are reports of leukopenia, low white blood cell counts, and increased risk of infection in the newborn. But again, the decision is with the doctor and the patient for that moment, and it can be a treatment to save the mother's life.
Perfect. Thank you. And then another question is it common for lupus patients to freeze their eggs?
It's becoming more and more common. I had this come up in my practice, and I know this is something that people do, especially if they're going to be exposed to cyclophosphamide. Then it's also a treatment that sometimes is necessary, and it is related to irreversible ovarian failure. So yeah, this is a possibility and an alternative.
Perfect. Someone said, thank you so much for your talk, Dr. Levy. I'm curious if research shows that cyclophosphamide yeah, causes infertility even at low doses.
So yeah, it's possible that the lower dosages with less risk, okay, but you can't really say that it's zero risk with the lower dosage. And as I told you, it's one of those that we pay more attention, because there's no fixed dose that we can say up to that much it's safe. So it depends on how it's used, the frequency, the full dose, and the individual response.
Perfect. Okay. The next question, it might be a bit too like personal, individual for it to give an answer. So maybe following up is best for this, but I'll ask and we can see from there. Is it safe to try and conceive if you have been in remission for 6 months on non-pregnancy safe medications and then switch to pregnancy safe medications and can stay stable for at least 3 months?
So there are some medications that will have a lifetime that is longer. So in the guidelines, there is a time frame when we say, stop this certain drug 3 months before conception, stop this one 1 month before. So depending on the medication and the way that is being metabolized, we can talk about timing. So I can tell you, I had many patients that came to me with methotrexate and said, oh, I'm pregnant. I didn't know I was going to get pregnant last month, and I was on methotrexate. So the ideal is to stop and plan. That's why I say, if you want to remember 2 words from everything we said, planning and timing, planning and timing, and be transparent with your doctor. Don't be caught by surprise. I bet you all know how you get pregnant, so it can't be a surprise. It has to be planned.
Thank you. I think that's all for our questions. So Leanne, I don't know if you have anything.
Yeah.
So let me make a quick comment, Liana. Those patients sometimes, and I mean, like you fall from the chair. They say, oh, I asked, you got pregnant on methotrexate or mycophenolate, and didn't your doctor tell you? And they say, well, my doctor told me I'm giving you this medication, you can't get pregnant on it. So the patient understood it's going to be a contraceptive. So saying that you're not supposed to get pregnant while using this medication doesn't mean that it's not going to let you ovulate or get pregnant, right? So make sure you understand what your doctor wants to tell you. If it's not clear, ask again, because I've seen this confusion. It may sound obvious for a doctor that tells the patient, but then the patient understand in a different way.
Thank you so much, Dr. Levy. I really appreciate this presentation. It's so thorough and gives so much great information to folks that are looking and hoping to have a family, and definitely like you said, planning and timing is key. And they need to speak to their healthcare team about when they're thinking about potentially having a family. So thank you so much for taking the time to present to our group. I know it's been extremely informative, and for folks who would like to listen back to the webinar, it is recorded and it will be on our website in 24 to 48 hours. Should you want to listen again to all the great information that Dr. Levy has shared with us this evening. Just end that with thank you again, Dr. Levy, for taking the time and presenting to our group. We really, really are honored that you were able to do that. Ariana?
Yeah, I might insert myself with another little plug. If you're new here, I usually have little plugs at the end, but I just wanted to share with everyone that Lupus Canada has their virtual silent auction fundraiser happening right now. So there's a lot of variety of different items. There's something for everyone. So if you're looking for holiday gifts for yourself, family, friends, please be sure to look at our website for more information. The auction closes in 4 days, and we've had so much participation so far. So thank you all if you have participated. And if you haven't, go check it out. And that's all I have to say.
Thank you, Ariana. Thank you for moderating. Thank you to everybody who participated this evening. We're sure you found it extremely informative. Thank you again, Dr. Levy. Have a great evening, everyone.
Thank you. Bye.
Bye-bye.
Bye.